I'll be talking about current practices in the management of children with failing allografts. This is preliminary data from the European Society of Pediatric Nephrology Working Group work that we're undertaking right now. Throughout the day, we have learned how we've improved kidney transplantation in children and improved outcomes. The allograft outcomes have improved with reduced rejection rates. Recurrence of primary disease is reduced because we know better about the disease. Progression of CKD is halted because we understand the mechanisms better. But there are some issues with this as well. Because these patients are on immune suppression, they can have viremias and urinary tract infections that eventually lead to allograft dysfunction. Cardiovascular outcomes we learned about earlier, where hypertension leads to allograft dysfunction, obesity and diabetes also plays a part. And it's not just about the allograft in itself, it's also about the growth of these patients, not just linear growth, but also developmental growth and quality of life. What I'm essentially trying to say is that however hard we try, most of the children will require another kidney transplant because we're transplanting them earlier in their childhood and we're transplanting more complex patients. They will probably require a kidney transplant before they've even transitioned to adult life. The estimated half-life of a really good kidney is probably between 12 to 15 years, and we know that adolescents have a worse 5-year survival of the graft than if the kidneys were transplanted at less than 11 years of age. We know the reasons for allograft failure. That's very well documented from this review a long time ago and subsequently since then as well. Chronic allograft nephropathy stays the biggest factor in allograft failure in children, along with disease recurrence, infections, which include viremias, and also non-compliance adherence, which is a big issue in the adolescent population. We do know that grafts fail, but we don't know what to do when they fail and how to look after them. KDIGO undertook a controversies conference last year in March, where clever people came together to try and understand how to look after patients with allograft failure. This is adult and pediatric. And they came up with 4 strategies of research that is important in this area because it's so poorly understood. One of them being understanding the definition of a failing graft, and I'll come to that in a second. We were involved, Yellen and I, doing this British Transplant Society guidelines for failing allografts, where we co-wrote the pediatric chapter. Although we went through the evidence, there was very poor evidence, as we know, and the data is quite scarce on what to do with these patients. So we wanted to understand how to look after these children. And in order to come up with guidelines as to how to best look after them, we have to know what we're currently doing. So that's what I'm going to talk about. So our project is actually the 3-step project. We're on phase 1 right now. We're looking at the current practices of management of these children across Europe. We then propose to prospectively follow up and understand the optimal management of strategies for these patients so that eventually we can produce some practice guidelines for good outcomes for these patients. For that, we did a 2-part survey. The initial survey was sent out in April 22, where we sent it to all the European Society of Pediatric Nephrology working group members in the 3 working groups of CKD, MBD, dialysis and transplantation. They were asked to respond to the survey. One was to try and understand people's appetite for such a thing, to understand failing allograft, but also to try and come up with a consensus of a definition of a failing graft, because we can't try and understand failing allograft till we actually have a definition of it. As you can see from the responses, there were many different variation of responses. We got 40 pediatric nephrologists from 34 centers who were interested in undertaking a further study. But as you can see, defining a failing allograft was different. So the definition varied from a decreasing EGFR from anywhere between 30 to 15 to actually commencing dialysis was one of the options. And as you can see, some of them actually said there was no definition because there was no consensus definition. So armed with this information, and also, there was lots of appetite, basically. What we're trying to say over here is that people had lots of functioning allografts and failing allografts, and there were lots of centers who wanted to have a follow-up study or a retrospective study to look at how we look after these children. Armed with this and having further discussions within the ESPN working groups, we set up our retrospective study, which I'm going to talk about now. And we defined failing allograft for the purpose of the study as an eGFR of less than 30 ml per minute per meter square for more than 3 months, as in it's irreversible damage that has already happened. We said we will look at children who had their transplant at the age of less than 18 years, and we do a retrospective data collection for 3 years. For centers who were already contributing their data to CERTAN, which is the collaborative registry for transplantation in Europe, we extracted the data from CERTAN registry to try and avoid duplicating the work for those centers and sent it out to them with an already populated Excel sheet. What we wanted to study was four aspects of failing grafts, four different aspects of failing grafts. One was cardiovascular outcomes of these patients. So in terms of hypertension, were they hypertensive at the time of graft failure? What kind of medications they were on? Were there dyslipidemias? Were they diabetic? Were they obese? Secondly, we wanted to look at their CKD, MBD. There is some data that's coming out from the CERTAN registry in terms of CKD, MBD in transplantation, but we wanted to look at failing allografts and management of anemia, acidosis, and growth in these patients. We wanted to look at what happens to immune suppression because we don't really understand what is the optimal therapy for immune suppression reduction in these patients. We don't know what happens with viremias or malignancy rates. And it's not just about the medical management, it's also about the management going forward. Certainly, someone who's had a failed transplant needs discussion about either further transplant or dialysis options, and actually a lot of psychological support for transition. Not just transition, but also transition to the next step because it's a big psychological burden. So, from the 34 centers who had expressed interest, we have results so far from the 17 centers, two of whom said that they did not have patients with failing allografts. So we have results from 15 centers to report right now, and this is unpublished data. So, and this is the first time anybody's hearing it. So all of them are from Europe actually, and three countries where we've got the most responses from is UK, Germany, and Italy, whereas we've got others who are going to be contributing as well. Thank you. So just demographics on the first instance. So we have 74 patients who we've got the results for, and 70 of whom had a first kidney transplant. For the purpose of this analysis, I'm only going to be talking about the 70 patients. The mean age at the time of transplant was 7.8 years, with a median age of 6 years. About 20% of them had preemptive transplantation, which is probably similar across Europe, but you would we don't know if that's an indicator. So obviously the numbers are quite small to make any statistical difference, but I'm just reporting as they are. There were about 36% of patients who had living donors, and their average mismatches were 2.7. The underlying etiology of children with failing allografts, the assumption would be that perhaps glomerular disease will make your graft fail quickly, but that wasn't the case. The spread of the disease is similar to what we would see as pediatric nephrologists. CACOT was congenital anomalies of kidney and urinary tract was far majority of the patients who had a failing allograft as well. And you can see the rest of the numbers are pretty much similar to what we see in pediatric nephrology. So coming specifically to their cardiovascular outcomes. So at the time of allograft failure, 3/4 of the patients were either hypertensives as described by their center, and I don't know what definition they were using, or they were on antihypertensive medications. As you can see from the graph over here, a majority of them were on combination medication, and by combination I mean more than one medication. Quite a few of them, some of them were on monotherapy. About 50% of them, so half of them, had a 24-hour blood pressure monitoring performed as a part of annual surveillance, and with 1/4 of them having left ventricular hypertrophy at the time of allograft failure. About 60% of them continue to have annual echocardiograms as a part of surveillance for their failing grafts. In terms of diabetes, annual surveillance for HbA1c occurs in about 40% of the centers, with about 10% of the patients reported as having developed diabetes post-transplantation. This is before graft failure. Annual lipid surveillance takes place in about 60% or 55% of the centers, with some of them requiring lifestyle modification and statins for reducing their lipid levels. Moving on to their CKD MBD surveillance. So as you can see, bone parameters are really important. The orange lines represent the normal range of phosphate and PTH, and you can see most of them have very poor control of PTH and phosphate, and that's a recipe not only for bone disease but cardiovascular disease going forward as well. And so very poorly controlled both uh, phosphate and PTHs. Quite a few of them were acidotic and anemic at the time of allograft failure. This data is from the time of allograft failure, and you can see about 50% of them were, more than 50% were anemic, and quite a few of them were acidotic at the time of allograft failure. But during the course of their follow-up, quite a few of them were on medication to try and settle down this issue. So vitamin D analogs, iron supplementation, and bicarb supplementation, along with erythropoietin and phosphate binders, which were started on during the course of their follow-up. Moving on to immune suppression changes after allograft failure. So this was a bit more difficult to pin down because it's very difficult in a retrospective analysis to understand at the time point where immune suppression changes took place. But from the data we have so far, most of the immune suppression changes took place when the patient started on dialysis, with some of the changes having taken place when the eGFR started to be below less than 30. Most of the patients, about nearly half of them, did not have any immune suppression change at all of the data we have, so it's not that much we have. 43% of them continued with all immune suppression as such, and quite a few of them were on triple immune suppression, so including CNI, antimetabolite, and steroids. When medication changes did take place, about 30% of them stopped their antimetabolite and continued with the CNI, and only a few of them stopped all immune suppression, and this was mainly after the initiation of dialysis and transplant nephrectomy. Ongoing DSA monitoring took place in about 3/4 of patients, with 1/4 reporting that they did not continue to monitor DSAs because allograft had already failed, and about 50% of the patients had a donor-specific antibody at the time of allograft failure. Viremia monitoring was prevalent throughout, with about 100% of the patients, only one not having a viremia monitoring. Otherwise, everybody had viremia monitoring ongoing as a part of allograft failures, with 2 patients who developed post-transplant lymphoproliferative disease, but that was prior to allograft failure, not after transplant failure. And about 10% of the patients had a graft nephrectomy after allograft failure. Moving on to the next step. So we think that's very important for these patients, especially not just in terms of CKD management, but to understand going forward the psychological burden of things. They need access to multi-professional teams. And we asked the question about if these patients had access to a dietitian and psychosocial team. And most of the children after the 70 had access to these teams. But as you can see, play specialists and youth worker were patients had less access to them. And obviously, they are very important in understanding the psychological burden for these families. In terms of next steps, when on the last follow-up, about 44% of the patients were back on dialysis, most of whom were either on hemodialysis or home HD, which is a bit out of keeping with what we would normally do because we normally start PD, but that's probably because of their access issues which they've developed over a period of time. And at last follow-up, 30% of the patients were either on lists for retransplantation or there were plans for retransplantation. About 70% were not. They were just getting medically better to try and get into that state. So in conclusion, chronic kidney disease is a continuum. I've heard that before. I think we all know that. It's not just the immune suppression after transplant. It's the bone disease and cardiovascular disease that will actually be the most harmful. These children with failing grafts have additional needs and hence need access to multidisciplinary team, and we definitely need more research to understand the optimal management for these patients. At the end, thank you so much to all of you, to everybody contributing centers, and I'd like to thank Farhad and Rukhsana. Thank you very much.
Great. So I have a comment and a question.
Yeah.
Comment would be when you present your blood pressure medication data, you amalgamated 2 different ways of looking at it, so into one graph. So you should separate one graph number of drugs and one graph the the classes of drugs? Because it'd be interesting to know in that really tall bar that has all of the kids with 2 or more drugs, how many of them are on channel blockers versus ARBs versus ACEs?
Can I just, so when the data is entered into the registry, they enter either a class or a combination, and that's how it appears in the registry.
Oh, so it's a
So,
failure of registry
well,
data. Yeah.
we can, it's very difficult, but that's the part that we will hopefully answer in the prospective part, because
Yeah.
these are the kind of
This
answers
is the
we need.
problem with any kind of,
Yes.
and sort of Steve will talk about this tomorrow at the research part, but you never know the data you're going to need
Yes.
until you actually do the study. And so if you didn't design the registry right in the first place, then,
It's it's
so,
difficult because you don't want too much data. You don't want to ask for too much data, and people
right,
then won't
there's
fill it
always
out as well.
a balance. So my question about the, Elaine and I were sort of going back and forth about the modality of dialysis. And so it might be interesting if you could suss it out as to either how many of the kids on hemo had a rapid loss of function and didn't have time to prepare for PD, or how many had previously been on PD and maybe didn't want to go back on it, or if you could figure that out.
Yeah. Yeah, we can definitely have a try and look. Again, might be tricky in the retrospective part, but we'll try and suss it out in the perspective.
Any other questions from the audience?
Do you have a feel for how many of these patients are having fistulas formed as part of their long-term?
We didn't ask the question, but yeah, we didn't ask the question, and I don't know if the registry asked that as well. But that's a really good one for long-term access.
It wasn't such a long time ago that in some countries you didn't get access to transplantation until you actually required dialysis.
Mm-hmm.
And in some countries as well, there was the mode in some units that your first kidney should have been ceased on because you wanted to keep the living donor
Options.
for your retransplantation, whereas now we believe trying to do preemptive living donor transplantation is the way forward. But you can still do preemptive living donor retransplantation. So I guess the question is, are we doing enough for our transplant population in managing their chronic kidney disease? Should we be thinking about, you've done the biopsy because of the recruitment crowd, and you can then predict how long it's going to take until the EGFR drops into single figures. And should we be planning for the families to move forward with working up a living donor maybe sooner? And it's not obviously one centre, so it's within Europe. But do you think that may be an issue that we're seeing?
I think it's important because we as transplant nephrologists also need to understand when the kidney is not going, it's irreversible damage done. Because the sooner we realize, I mean, by me as I mean the whole MDT, the more easier it is for us to then speak to the families about it, because obviously they're reliant on us for that information and how to move forward. It's difficult to deal with the acidosis and all that part and get them medically fit if we are not getting to the point. I mean, we should be doing it as a continuum, like I said, but I think we need to be more proactive in trying to get these. And the patients we managed to get preemptively transplanted are the ones that we've actually spoken to a lot in advance about this is not working. We need to get the next steps going. So I think, yes, there is some way in that. And hopefully with more education, we can get there.
And most of the work we're doing about access to transplantation, Jesus from my fellows who is doing a PhD who can come here today, is about, is it open access to everybody? So looking at ethnicity, socioeconomic class, and I suspect it's the same when we look at the data will be for the retransplantation as well as for the first.
And one thing what we haven't tackled here, which is very difficult to talk or understand, is adherence as well. There are some centers where would say you will have to make sure that you're adherent before you get an access to second transplant, because there's more likelihood of failing the second transplant as well. And it's very difficult to understand or actually know when you're actually now adherent to then say you're okay for. So that's something didn't we even get there, because that's a whole different.
Great.